So we're going to be talking about the AD8. So first, we're going to be going over some symptoms of dementia, how to diagnose dementia, then address some more traditional cognitive tools and what these tools may be missing. And then we're going to touch on how some caregivers, care providers, or informants, how these folks can aid in the evaluation of dementia. And then what are some potential of those early signs or some changes or declines that we could be looking for that Ms. Rosenthal was already touching on. And then we're going to dive into our AD8 assessment and conclude with some practice using it. So following this discussion, I'm hoping that you'll be able to understand history and its importance in the diagnosis of dementia, also describe how a caregiver, a care provider, or just an informant can really help in this evaluation of dementia, and then demonstrate the correct use of the AD8 screening tool. So we'll start, and we've gone over this already some in the first session, but we're just going to start with just kind of looking at, this quick overview of what dementia is and what these symptoms would be. So, rather than a specific disease, dementia is a group of conditions characterized by impairment of at least two brain functions, such as memory loss and judgment. So symptoms of dementia could include forgetfulness, withdrawal from social activities, confusion with time or place, and then also a difficulty in completing familiar tasks at home, as Ms. Rosenthal already mentioned. So we're going to come back a few times to these list of symptoms as we kind of look at some of these different screening tools. So in the past, dementia or any Alzheimer's disease and related dementia was only diagnosed for certain after death when they were able to look at the brain under a microscope and look at any plaques or tangles that were going on. But now, healthcare professionals are able to diagnose dementia with a little bit more certainty. But however, there is no single test to determine dementia. It's an evaluation with a few different approaches going on. So these could include a diagnostic laboratory test or other imaging. And this isn't necessarily done first, I'm just showing it first, but this would include maybe blood test, brain imaging. And I'm just going to quickly go over this because I really want to touch on some things that are more practical to us as non-clinicians, but just know that this is part of the ways that is involved in the diagnosis of dementia. It's also really important to obtain medical or family history from the individual. So this could include psychiatric history, a history of cognitive and behavioral changes, if that individual knows anything about dementia or related conditions in the family. There are some limitations surrounding this, of course, because this individual may not understand the changes going on. They may not be familiar with the family history. So it's a little bit more subjective and there's a little bit of limitations surrounding this. And then we have an approach of using a cognitive test or other neurological examination to assess dementia for that individual. So this is routinely used in primary care because the CMS recommends that anyone 65 or older be screened for this annually. And you may be familiar with a little bit of what these look like already. So these are some of the most traditional cognitive screening tools. This is the Mini Mental State Exam, the MMSE, and the MoCA, the Montreal Cognitive Assessment. So if you're a professional, you may have used these before. If you're a caregiver, you may have heard some of these questions being asked, like what day of the week is it? What's the year? What state are we in? And truly on any given day, like I could be getting what the day of the week is wrong too, right? Yeah. So these are the most routinely used, but there's some limitations around these too because they could be influenced by non-cognitive domains. They're not necessarily reliable across cultures, and they can also be influenced by language, levels of literacy, and cultural and ethical norms. And particularly the MMSE, which is the most commonly used, that isn't able to really detect those earlier signs of cognitive impairment that Ms. Rosenthal was mentioning. And also, it's doesn't work as well among highly educated older adults. and both of these ones too do require some training involved, so they could be less practical for use among non-clinicians. So if we look back at our laundry list of symptoms, these are some of the areas or symptoms that those measures, the MMSE and the MoCA, are kind of hitting on. So they kind of look at memory, such as this. They're asking about a short memory recall. Earlier I told you to name 3 objects. Can you tell me what those ones were? So that's kind of looking at that domain. And then we have problem solving abilities is also looked at as well in these ones. So this is the trail making test that's included in the MoCA. Sorry, all right, and then they also look at orientation to time and place, because they are asking you, what's the year, what's the date, where are we? And then these ones as well also assess your, sorry, my tracks, okay, they understand, assess your understanding of visual images and spatial relationships. So however, we do see a lot of other symptoms listed here, right, that aren't really assessed with these more traditional cognitive screening tools. They're not able to really look at changes in activities, difficulty in usual tasks, and decreased judgment, and changes in mood. And partly because some of these are changes, and this is just a test you're conducting in real time, and you don't necessarily have a baseline to compare it to from earlier in their life. So that's a limitation around these ones. So this is when it does really come in handy to have this other area that can aid in the diagnosis of dementia, and that's input from a family member, a caregiver, or a care provider about changes in this individual and their thinking skills, their behavior, and just their overall history as well. You could get input from as well. And some prior research has shown that caregivers and care partners are really capable of recognizing these symptoms of dementia. And if you are one of these folks, I'm sure you know that already. It's really obvious because you're with them all the time and you're aware of seeing these changes. So I just wanted to highlight here some excerpts from qualitative interviews on how they identified early signs of dementia. So this one says, she turned on the gas stove, forgot what to do, and went to the study room, leaving the gas stove on. She could not find her way to go to the places in the neighborhood she was familiar with before the memory problem. The behavior of my husband changed. He just did not respond when I needed help or when I needed an arm around my shoulder. My husband became forgetful, forgetting appointments or where he put his keys. He did just not forget things, but he wasn't even capable of imagining where he could have put his car keys. Normally when you forget something, you remember again when someone reminds you, but he did not have that. It just didn't come back. And these were some of the things also that Ms. Rosenthal was illustrating in her talk for us earlier. So then what do we do if caregivers hold this vital information and it's not normally looked at in some of these cognitive assessments that are used in primary care settings? Well, there are some measures and tools that do consider some caregiver or just informant information. And we're going to talk about that today because the AD8 is one of them. But these are some of the areas that caregivers or care providers can aid in. One of the main factors to focus on during the detection of cognitive impairment is the onset of obvious change in a person's mood or behavior. So if an older adult is experiencing symptoms related to dementia, it should only raise concern if these, again, were a recent occurrence, not something that was a lifetime issue necessarily with behavior. Additionally, an informant can help provide any family history of dementia or other relevant medical issues. So being able to obtain this would be really helpful in the evaluation of dementia, and a caregiver or care provider would be someone that you could go to for this information as well. And then finally, caregivers or informants can identify any changes in ability to perform daily tasks. So this could be a common theme that seems to surround the issue of early diagnoses is, maybe being aware of these changes but not knowing that, this could be associated with dementia or such. So they could be recognized but maybe not understood the severity of the problem. So really today I want to highlight, what are some of these changes and why do they matter in relation to evaluation of dementia, which we'll talk about on this slide. So because we are non-clinicians, I really want to help us clue into some of these concepts that are really important. which would be the instrumental activities of daily living. So these are activities that you do every day to care for yourself or your home. They do require more complex planning or thinking compared to activities of daily living, which would be bathing, dressing, or washing. So instrumental activities of daily living, and Ms. Rosenthal mentioned these a little bit already, but this would be related to paying bills, balancing a checkbook, placing calls, being able to get around the neighborhood in car, bus, or however you normally do. And usually the ability to perform these tasks is the first to decline in individuals with dementia, whereas they're normally able to perform those more basic ones, just the bathing and dressing, that remains intact for longer than these ones do. So it's really important that we look for some declines in these areas when we consider evaluating dementia and screening for it. And these are some of the more difficult to measure in terms of the standard cognitive measures that the individual completes. Again, because these are changes that occur over time and you don't necessarily have a baseline when you're using some of these more standard ones. So again, this is information. Some of these changes really could be obtained from a caregiver or a care provider or just other informant who knows the individual, where they're able to relay the fact that this individual no longer keeps up with their hobbies. They used to do XYZ, but they don't any longer. They're having difficulty managing bills. So it really paints a better picture of some other these symptoms that we can look at that aren't normally captured in some of the more standard screening measures. So now we do have the AD8, which is a practical tool in which the informant is asked to rate the change over a period of time from earlier in life. Most of the time, a specific date range isn't given when administering this, but they do ask sometimes just over a period of years. And this was developed by Dr. Galvin, so it really is practical, engaging dementia through the loss of abilities over these 8 yes or no questions related to memory, orientation, judgment, and daily activities that we talked about is really important for inclusion in some of these measures and screening tools. So the items it looks at, it's kind of small, but it is, it's problems with judgment, less interest in hobbies or activities, repeating the same question or stories over and over again, trouble learning how to use a tool or a gadget, forgetting the correct month or the year, which again, that could happen to anyone, especially me at the start of the new year. I'll be forgetting for a while which year it is. Trouble handling complicated financial affairs, and trouble remembering appointments, and then also a change in daily overall problems. So all of these you'd be asking, has there been a change in this? Yes or no, over years or over time, has there been a change in this? So this is ideally given to an informant, such as a family member or a caregiver. It can be done via mail, over the phone, or in person. It's really flexible in regards to how it can be completed. Some research has even shown that it can be directly administered to the individual themselves. Although that is more common, this would be better with someone who knows the individual rather than the individual themselves, but it's still an option. And then to score this also is really simple, and why I think it's really helpful for us as non-clinicians, because it's very simple. Some measures require algorithms, this one doesn't. This one is just you get a score of 1 for each item you mark that there was a change, and then you just sum those. So the total score would range from 0 to 8, with any score 2 or greater would be indicating likely cognitive impairment. You may want to be doing some further evaluation. But any score that would be 0 to 1 would be normal cognition likely. So this has also been more successful in detecting dementia compared to other similar informant-based screening tools. And I'm briefly going to touch on how we determine if this is an adequate tool to evaluate dementia on the next slide. So to give you some context on how the AD8 kind of holds true as a screening tool for dementia, we will discuss kind of what we use in research to assure that a tool measures something, and in this case, that something would be dementia or cognitive impairment symptoms. So Briefly, I promise I'll just only for a second get into the nitty-gritty. So reliability and validity are concepts we use to evaluate the quality of this as a measure. So reliability is about the consistency of a measure. So like if you had a bathroom scale, it would be reliable if every time you got onto it, it was giving you the same number and it doesn't fluctuate. And then we're also looking at validity, which is the accuracy of this measure. Is it measuring what you intended for it to measure? So this has been proven to be a reliable and valid tool in several different populations among white older adults and other non-white communities of color. But if you were going to use the AD8, there are some ways that you can help to ensure that it's a reliable tool itself just when you are using it. One way you can do this is called inter-rater reliability, in which there's going to be you and someone else completing this AD8 assessment on an individual. So inter-rater reliability is the level of agreement between the two raters. So if everyone were to agree, that agreement percentage would be 100%. But if there was no overlap between the items you selected at all, then the agreement rate would be 0%. And I'm going to show us how we would do this because this would be helpful if you were doing it. So how we do determine this is once you and your partner complete the AD8, you compare your answers to the items. And if you both mark the same items, you count them and see how many are different. So here we can see, and I'm sorry that it's a little small, but here we can see that the two raters all agreed on all items except the second item, which was about a change in hobbies or activities. So to determine their inter-rater reliability, we would just be counting the number of ones that they agreed upon, which was 7, out of the total number of items, which was 8. So we divide 7 over 8, and that gives us 87.5%. So that's their inter-rater reliability, their percent agreement rate. So this would be considered a reliable assessment that you've just done. Anything over 70 or 75% is good reliability. So this one would be a job well done. So this is a way that if you were to administer this to someone you know, a client or a loved one, you can have someone else kind of jump on in this with you, compare your answers, and then just get a quick little determination of if that was a reliable assessment or not. So now that we are familiar with using the AD8, we'll just give it a little shot at using it. So let's say you have a client, a neighbor, aunt, or mom, or whoever it is, that's saying she has trouble with remembering names, but other than that, she's really unaware of any other issues. But otherwise, her husband is more concerned. On the other hand, he lives with her and he recounts some recent events. He says that she has been forgetting appointments. She used to be an avid reader, but is not any longer. She used to manage finances, but has been having trouble balancing the checkbook. And she's been asking the same questions over and over again. She does get routine cognitive screening at her primary care, but they use the same screening tool annually. And in this case, we'll just say it's the MMSE because that's the most common. And if we do recall, that's the one that has trouble detecting these early symptoms of dementia. And I can even speak to this case with someone I know that, she gets this done annually, and she really prides herself on getting the answers right. She'll even practice before she goes to her appointment. So she remembers all those answers year to year because they use it every time. But her husband is saying, there's some other things going on at home. I'm not sure about this. So let's say you're a professional, you're a caregiver, you just want to give the AD8 a shot. So we're gonna look at this in her scenario. So what would her AD8 look like if we were to ask the husband? Well, she has been forgetting appointments, so we can put a check there. She was a reader, but is now not interested in that hobby, so we'll put a check there. She always did the checkbook balancing, but cannot any longer. And for this one, I will gently remind you, like if she had never done the checkbook balancing or managing the finances, we wouldn't mark that as a change because she'd never done it. So only if there had been a recent change would we put that one there. And then finally, she was also been repeating questions. So her total score would be a 4. And again, any score of 2 or greater is likely of cognitive impairment. So, we would maybe recommend, grandma, maybe let's go talk to a specialist. So that would be her AD8. So now that we've kind of gone over this and you can see how it's really intuitive and why it requires no formal training, it's super straightforward. I wanted to give us a few minutes to test our skills. So it is, I think, on page 13-ish of your booklet. We'll just take a few minutes. You can either complete it yourself on someone you know. You can administer it to someone else, asking someone else about their loved one or someone that they know. Or if you've come with someone else today, you can even give it a shot at inter-rater reliability, in which you both ask someone else and mark those questions down, and then just try your hand at comparing your scores and seeing how well you did. So we'll just pause for a few minutes, just give ourselves a hand at a try at completing this, and please reach out with any questions. So group effort, straightforward tool. I really like it. As we wrap up, I wanted to just recognize some of the limitations of the AD8 and just other dementia screening measures. As we're already mentioning, this will need to be changed down the line probably. But for this one particularly, a limitation of it is because it's really based on an informant. So if you don't have an informant available, no family, no friend, or anything like that, it's not so much of a good as a tool to administer it to the person. So you're really dependent on the availability of someone else to complete this. And then again, you also want to assure that the informant is reliable and has a good understanding of this individual, because there could be some subjective biases and over-reporting of these as well. So you want to make sure that, if you were going to be asking someone these, that, they're a family member that is involved with the care or knows this older adult or individual pretty well. And then if you are a professional, you could always ask the family, who'd be the best person for me to speak to about this. And they're happy to point you in the direction of, who's the primary caregiver or whoever. So that's always an avenue you could take too. And because each dementia screening tool has its own strengths and limitations, I do recommend, and it is recommended, that you use an array of assessments to evaluate dementia. So we did talk about there's there's 4 different ways that the diagnostic test, the history, and all this. But even when you're just looking at the tests themselves, you could use a variety of assessments. So like the AD8 is administered to an informant. You could also combine this with the mini cog that another session is on today, or the MMSE, even though it has some limitations, you could get that picture of, here's what the family member, the caregiver, is saying about the changes, and then when I go to administer this to the individual, where's their score? So utilizing multiple assessments to kind of guide this process is really recommended to kind of balance some of those limitations they each have. So you can definitely use them in tandem. And then also, it really is important for some of these tools to be considering the education and literacy levels, because some of them, just like the MMSE, just really aren't appropriate for those with lower educational level or lower literacy level. So you want to be conscientious of that. So another one that you could use that was developed for those with lower educational and lower literacy levels is the PIZZA test, which is a newer one, and it's an alternative to the clock drawing test that you all were talking about this table. So, because I wouldn't be able to do the clock drawing test probably, but we have the PIZZA now. So this one, you're asking the individual to slice it or cut it or however into 6 pieces for family or whoever. And then when you score it, you're judging it off of, it's the size of the pieces, the number of the pieces, and the shape of the pieces. So that's how you get the score for that. And I won't get into all that, but just know that, there are For those who maybe have lower education or lower literacy, there's some other assessments that may be more appropriate for them, such as this one. And also the Alzheimer's Association website does list several dementia screening tools, a whole bunch for you to consider that I didn't even get into today. So you can check there too. So just to conclude, we know that these caregivers, these care providers, these informants have crucial information to share about their loved one's cognitive changes. But these routine dementia screening measures aren't really based on this input from these individuals. So just keeping this in mind that there are some tools that you can use that get input from these individuals that could be really helpful. And it's particularly important to pay attention to those changes in those daily tasks or those instrumental activities of daily living, because those are likely to be the first that decline for those with cognitive impairment. So we do have the AD8, that's that practical, super easy to use to assess those changes in activities, but it also does look at those other domains such as memory, orientation, and judgment. Scoring is easy. So it can really be a helpful tool for professionals and caregivers alike to kind of get an easy assessment of the possible cognitive impairment to follow up with some other evaluation if needed. So that concludes with that. So I'm really grateful for y'all for being a part of this discussion today. I know that you're all really passionate about this. So thanks for joining me today about understanding how we can better evaluate cognitive impairment. Happy to take any questions, and my email is also here as well, so feel free to reach out. But thank you very much, and happy to take any questions. Thank you.